Welcome to the Deep Dive, your shortcut to being well-informed on complex topics. We aim for surprising facts, useful insights, and hopefully just enough interest to keep you hooked.
Yeah.
Today we're diving into the really compelling world of abnormal behavior and how we treat it. And to really ground us, let's start with a scenario. We're calling it Jessica's Secret.
Okay. So Jessica is a bright 20-year-old. She's a communications student, but she's secretly battling bulimia nervosa. Her whole life kind of revolves around these cycles of binging and then purging.
Right.
And it's all driven by this really intense consuming fear of gaining weight. It's it's not just about food. It's actually physically damaging her decaying teeth from stomach acid.
Ooh.
Yeah, and it's profoundly impacting her relationships too. She's hiding it even from her fiance. She actually told her therapist, "I don't want Ken to find out. I don't want to bring this into the marriage." Her behavior is deeply, the term is maladaptive.
Maladaptive, meaning
it's actively hurting her, it's disrupting her life, making her distressed. And while it might seem rare, maybe not as statistically infrequent as you might think.
that's a really powerful example. So how do we even begin to understand someone like Jessica? I mean, how do we help her untangle this really complex web? That's basically our mission today. This deep dive will unpack the different lenses, the different ways experts look at abnormal behavior, from our biology, our wiring, to the mind itself, and societal influences too.
Right. All those layers.
Yeah. We're offering you a shortcut to the key insights into why people develop psychological disorders and, maybe most importantly, how they're treated. Our source material for this is a pretty comprehensive chapter on contemporary perspectives, and we're trying to distill these complex theories into something, accessible.
Makes sense.
Okay, so let's try and untangle this.
Yeah.
To really help someone like Jessica, we first need to understand why. Why does abnormal behavior happen? So where do experts even begin? It seems so huge.
Well, a major starting point often is the biological perspective. The basic idea here is that abnormal behavior stems from physical, biological issues within us. It's this view that gave rise to what we call the medical model.
The medical model, like treating mental illness like a physical illness.
Exactly. Seeing disorders as symptoms of underlying illnesses that have biological causes, much like diabetes or heart disease.
So it's really about our brain's circuitry. It's chemistry. What are the absolute must-know parts of our biology that play a role here?
Okay, so the fundamental messengers are neurons, right? Nerve cells transmitting signals. But what's truly striking is how tiny chemical messengers called neurotransmitters dictate so much.
Things like
serotonin, dopamine, acetylcholine, norepinephrine. They work like a lock and key system across tiny gaps between neurons as synapses.
Right.
And when these systems get out of balance, it's not just a small shift, it can profoundly disrupt mental well-being. For instance, serotonin imbalances are famously linked to depression.
Yeah, everyone's heard of serotonin.
Right. And dopamine irregularities are linked to schizophrenia, while reduced acetylcholine is implicated in Alzheimer's disease. This is why many psychiatric drugs work, by targeting the availability of these specific chemicals.
It's fascinating, isn't it? How something so small chemically can have such a huge effect on mood, thought, behavior.
It really is.
And beyond these chemical signals, what about the brain's bigger structures, the systems?
Well, you have the central nervous system, brain, and spinal cord, the body's sort of master control. But maybe more critical for this discussion are the brain's emotional and higher thinking centers, like the limbic system that's key for emotions, memory.
Okay.
And the cerebral cortex responsible for, everything from problem solving to perception. When these areas show abnormalities like structural differences observed in the cortex and limbic system, in some patients with schizophrenia, it can be a significant piece of the puzzle.
In the autonomic nervous system, the automatic stuff.
Right, the part that handles things without us thinking, that's divided into two key players that often work in opposition, doesn't it?
Yeah, the sympathetic and the parasympathetic branches.
Yeah.
One speeds you up, the other calms you down.
Exactly.
So it's easy to see how, an overactive sympathetic system, always in fight or flight, could fuel anxiety disorders.
Absolutely. That constant activation of the alarm system can have real physical and psychological consequences over time.
Okay, now this is where it gets, for me anyway, truly mind-bending.
Yeah.
The whole nature versus nurture thing. We used to think it was kind of one or the other, didn't we? But it's way more complex.
Much more nuanced, yeah. While genetics certainly creates a predisposition, A likelihood it's almost never a certainty for these complex disorders.
So not like inheriting eye color.
Not at all. Psychological disorders typically involve multiple genes interacting with environmental factors. It's a common myth, this idea of a single depression gene or schizophrenia gene. In fact, there's a question here. True or fiction scientists have not discovered any one gene that causes a psychological disorder.
Based on what you just said, I'm going with true.
That's entirely true. It's always a complex interplay, and this leads us to a really fascinating field called epigenetics.
Epigenetics. Okay, I've heard of this.
Yeah, it's groundbreaking. The core idea is how environmental factors, things like severe stress, childhood trauma, maybe even diet, can literally turn genes on or off.
Without changing the DNA code itself.
Exactly. Without altering the underlying sequence. So your life experiences can actually influence how your genes are expressed, affecting your traits and your vulnerability to disorders.
Wow. Okay, so if we can understand how genes get switched on or off by the environment, then this next idea, true or fiction, we may someday be able to silence certain genes or activate others to treat or even prevent psychological disorders. That sounds like science fiction, but maybe true.
Based on epigenetics research, that is increasingly looking like true. It's a very real and, frankly, tantalizing possibility for future treatments. Still a way off, probably, but possible.
Okay, so the big takeaway from the biological perspective, for someone like Jessica, or for any of us really, it underscores that mental health isn't just all in your head. It's deeply connected to our biology, our brain chemistry, our wiring.
Absolutely fundamental.
But biology isn't the whole story, right? The mind itself, our inner world, offers powerful explanations too. Let's dive into that psychological perspective, starting with the psychodynamic models, Freud territory.
Yeah, got to start with Sigmund Freud. His psychoanalytic theory, well, it was radical at the time. It introduced the idea that our unconscious motives and conflicts, often stemming from childhood and primitive instincts, powerfully shape our adult behavior.
The famous iceberg analogy, right?
Exactly. Only the tip, our conscious thoughts, is visible. Below the surface lies this vast, mysterious unconscious, holding basic impulses, hidden memories, unresolved conflicts.
And he broke personality down into 3 key players, didn't he? The id, ego.
And superego, yes. The id is our primal pleasure-seeking part there from birth. The ego, developing in the first year, is the rational mediator trying to balance the id's demands with reality and social constraints.
Reality principle.
Right. And then the superego, our internal moral compass, emerges later, embodying societal rules, judging right from wrong. The ego is constantly juggling these often conflicting demands.
Sounds stressful for the ego.
It is. And to manage the anxiety this creates, the ego deploys what Freud called defense mechanisms.
Defense mechanisms.
Mm-hmm.
Like denial.
Denial is a classic one. Also repression, regression, rationalization, lots of them. The core idea is they're like mental stop signs protecting us from anxiety. For instance, someone with a serious heart condition who completely ignores health risks, that's denial in action. They can be helpful short-term, maybe, but overused, they distort reality and cause bigger problems.
It's almost like our brain has its own internal PR department, trying to manage our image even to ourselves. We all do it. But I guess when that PR goes into overdrive, that's where trouble starts.
That's a great analogy, yeah. Precisely. And while some of Freud's ideas, like his psychosexual stages, the oral, anal, phallic stages with the Oedipus complex are pretty controversial and hard to test.
Yeah, controversial.
Their lasting impact is undeniable. He suggested that early childhood experiences, specifically fixations at these stages, due to too much or too little gratification, could shape adult personality traits. Like, say, an oral fixation potentially leading to overeating or dependency.
But psychodynamic thinking didn't just stop with Freud, did it? Others built on his idea.
Absolutely. Carl Jung talked about a collective unconscious filled with universal symbols or archetypes like the hero, the wise old man influencing us all. Alfred Adler focused on the inferiority complex and our drive for superiority.
Right.
Karen Horney highlighted the importance of child-parent relationships and basic anxiety. And Erik Erikson really broadened the scope, emphasizing psychosocial development across the entire lifespan, focusing on social relationships and identity.
So not just childhood.
Not just childhood. And Margaret Mahler's object relations theory looked at how we internalize representations or interjects of important people, shaping our sense of self.
So the big takeaway from all these psychodynamic theories, even with the debates and difficulties in testing them,
yeah,
they fundamentally changed how we view mental health, didn't they? By really spotlighting the huge, often hidden influence of the unconscious and our early experiences.
Absolutely. That legacy is profound, even if we approach the details differently now.
Okay, so if biology shapes our predispositions and the unconscious shapes our inner world. Next up are the learning-based models. This seems more about observable behavior, right?
Exactly. From this perspective, abnormal behavior isn't necessarily a symptom of some deep hidden conflict. Often the behavior is the problem, and it's learned through our interactions with the environment, just like any other behavior.
So things like classical conditioning, Pavlov's dogs and all that.
Precisely. Ivan Pavlov's work showed how we form conditioned reflexes associating stimuli. Think salivating at a bell, and John B. Watson's infamous Little Albert experiment.
Oh, the poor baby.
Yeah. Ethically questionable today, but it demonstrated how fears and phobias could be learned through association. By pairing a white rat with a sudden loud noise, he conditioned the baby to fear the rat. It shows how powerful simple association can be in creating fear responses.
And then there's operant conditioning. That's more about consequences, right? Rewards and punishments.
Correct. B.F. Skinner was the pioneer here. He showed that behaviors are strengthened or weakened by their consequences. Reinforcers increase behavior.
Positive and negative reinforcers. Gets a bit confusing.
It can be. Positive reinforcement adds something pleasant, like praise, to increase a behavior. Negative reinforcement removes something unpleasant to increase a behavior. Think taking aspirin removes a headache, so you're more likely to take aspirin next time.
Right, so it's not punishment.
Exactly, that's the key distinction. Punishment decreases a behavior by adding something unpleasant or removing something pleasant. Negative reinforcement increases behavior by removing something unpleasant. Crucial difference.
Okay, got it. And then social cognitive theory kind of builds on this.
It does. Theorists like Albert Bandura, Julian Rotter, Walter Mischel expanded the view. They added the critical element of thinking cognitions, expectations, and observational learning, also called modeling.
Learning by watching others.
Yep. You might develop a spider phobia just by watching your parent react with terror to a spider, even if you've never had a bad experience yourself. We learn by observing, processing information, anticipating consequences, not just through direct reward and punishment.
So the practical relevance of this whole learning perspective for us, it feels like it gives us very direct tools for change, doesn't it? If behaviors are learned, they can potentially be unlearned or replaced.
That's exactly the implication. It forms the basis for many effective therapies, as we'll see.
Now, moving to a very different angle, humanistic models. These seem to focus much more on our potential for growth.
Very different focus, yes. Humanistic psychology emphasizes personal freedom, conscious experience, and this inborn tendency we have towards self-actualization.
Self-actualization.
Yeah.
Becoming your best self.
Essentially, yes. Striving to fulfill our unique potential, to be authentic. From this view, abnormal behavior arises when this natural growth process gets blocked or distorted.
And what causes those roadblocks?
Well, Carl Rogers, a key figure, talked about conditional positive regard from parents, meaning children feel accepted and loved only when they behave in ways the parents approve of.
So they learn they're only worthy if.
Exactly. They develop conditions of worth, internalizing the idea that their value depends on meeting external standards. This leads to a distorted self-concept where they deny their genuine feelings and experiences if they don't match those conditions.
So the core message here is, anxiety and distress pop up when our true feelings, our genuine self, clashes with this distorted self-image we've built to get approval.
Precisely. We deny parts of ourselves to feel worthy, and that creates inner conflicts and unhappiness. The challenge with humanistic models, though, while they offer valuable insights into subjective experience and growth,
They're hard to measure.
yeah, concepts like self-actualization are inherently subjective and difficult to define and measure scientifically, which has been a criticism.
Okay. And then we land on cognitive models, which really put our thoughts front and center stage.
Absolutely. This perspective argues very strongly that it's our cognitions, our thoughts, beliefs, expectations, interpretations, that primarily determine our emotional responses, not necessarily the external events themselves.
So it's not what happens to you, but how you think about what happens to you.
That's the core idea. Distorted or irrational thinking patterns, sometimes called cognitive distortions, are seen as the root of emotional problems. Cognitive psychologists often view the mind kind of like a computer processing information, and problems arise from errors or bugs in that processing.
Can you walk us through an example? How does this play out?
Sure. Albert Ellis, a major figure, developed the ABC approach. A is the activating event, say, losing your job. C is the consequence, feeling miserable, depressed.
Okay.
But Ellis said A doesn't directly cause C. The crucial link is B, your beliefs about the event. If your beliefs are irrational, like this is awful, I'm a complete failure, I'll never find another job, that's what leads to the misery.
C, not the job loss itself, but the interpretation.
Exactly. Ellis really focused on the tyranny of rigid musts and shoulds. I must be perfect, everyone should like me. These set you up for distress. So here's another true or fiction. According to a leading cognitive theorist, emotional problems result from what people believe about their life experiences, not from the experiences themselves.
Based on Ellis. That sounds definitely true.
That's true. It captures the essence of his approach.
Mm-hmm.
And Aaron Beck, another giant in cognitive therapy, detailed specific types of these thinking errors, these cognitive distortions.
Like what kind of errors?
Things like selective abstraction, focusing only on your flaws and ignoring positives. Overgeneralization, drawing sweeping negative conclusions from one minor event. Magnification, blowing things way out of proportion. And absolutist thinking, seeing everything in black and white, good or bad, no gray areas.
I think we can all recognize some of those in ourselves sometimes.
Oh, absolutely. We all do them to some extent. But when they become rigid and pervasive, they contribute significantly to disorders like depression and anxiety. This cognitive perspective has had a massive impact on understanding and treatment.
Okay, so we've gone from biology to the unconscious to learning to self-actualization to thoughts. Finally, let's broaden the lens right out with the sociocultural perspective.
Right. This view reminds us that abnormal behavior doesn't just happen inside an individual. It's also profoundly shaped by the wider social and cultural context. Factors like poverty, racism, discrimination, gender roles, social class, they all play a part.
Some even argue the label abnormal is itself a social construct.
Yes, some theorists argue that abnormal is essentially a label society attaches to behaviors or people that deviate too far from accepted norms, sometimes as a form of social control.
What's really striking here are some of the findings about prevalence rates across different ethnic and cultural groups. It's not always what you might expect.
It's quite revealing and sometimes surprising. For instance, research has consistently found that traditionally disadvantaged groups in the U.S., like non-Hispanic Black Americans and Hispanic Americans, often report lower rates of many current psychological disorders compared to white Americans. Asian Americans generally show lower rates too.
Lower rates? That seems counterintuitive given higher stress levels often associated with minority status.
It does. However, and this is a crucial nuance, when disorders do occur in Hispanic Americans and Black Americans, they often tend to be more persistent, more chronic, and sometimes more disabling than in white Americans.
Okay, that's a critical distinction. And the situation for Native Americans, that seems particularly concerning.
It really is. Native Americans face disproportionately high rates of depression, substance use disorders, anxiety, and tragically, suicide, particularly among younger people. This is widely seen as inextricably linked to factors like poverty, high unemployment, lack of opportunity, and the profound, enduring historical trauma of colonization, forced assimilation, and ongoing marginalization.
So it's clear that social stressors like racism and discrimination aren't just unpleasant experiences.
No, they are significant stressors that have a measurable impact on mental health for people from ethnic minority groups. They contribute to the burden of stress these communities face.
So if we connect this sociocultural view to the bigger picture, it really forces us to look beyond purely individual factors, doesn't it?
Yeah.
We have to consider the systemic issues, the societal structures that deeply affect mental well-being across different communities.
Absolutely. It adds a vital layer of understanding.
Okay, so we've explored biological, psychological, with all its different flavors and sociocultural lenses, but the big takeaway seems to be no single one of these tells the whole story, right?
Exactly right. None of them alone provides a complete picture. That's where the biopsychosocial perspective comes in. It's become the dominant model today precisely because it offers a more holistic, integrated view.
Biopsychosocial biology, psychology, social factors, all interacting.
Precisely. It explicitly recognizes the complex interplay between these different domains. It's not just one cause, but usually multiple factors interacting in intricate ways to produce psychological disorders. A really key example of this integrated thinking is the diathesis-stress model.
Diathesis-stress. Okay, how does that model specifically tie these different threads together?
It proposes that psychological disorders develop due to a combination of two things, a diathesis and stress. The diathesis is a vulnerability or predisposition for a particular disorder. This is often thought of as genetic.
Like we talked about earlier.
Right, but it doesn't have to be purely genetic. It could also be psychological, like having insecure early attachments or possessing certain maladaptive personality traits or ingrained negative thinking patterns. It's some kind of underlying vulnerability.
Okay, so you have the vulnerability.
The diathesis.
And then that vulnerability interacts with stressful life experiences.
Right.
These could be major events like trauma, loss, or chronic stressors like ongoing poverty or discrimination. The model suggests that the stronger your underlying diathesis, or vulnerability,
The less stress it might take to trigger the disorder.
exactly. Someone with a strong predisposition might develop a disorder under relatively moderate stress, while someone with a weaker predisposition might only develop it under conditions of extreme or prolonged stress. Or maybe never, if they don't encounter significant stressors.
Okay, let's bring this back to Jessica, our example with bulimia. How might the biopsychosocial model help us understand her struggle more completely?
Well, her bulimia likely arises from a complex mix. Biologically, perhaps there's a genetic predisposition affecting appetite regulation or mood, or maybe irregularities in neurotransmitter systems like serotonin, which is implicated in eating disorders.
Okay, the bio part. Then psychologically, you have factors like her intense fear of weight gain, body dissatisfaction, maybe perfectionistic tendencies, black and white thinking about food, good versus bad, low self-esteem, perhaps difficulty coping with negative emotions.
A lot going on internally.
Right. And then socioculturally, there's the immense pressure in many Western societies, especially on young women, to achieve an often unrealistic thin ideal, constantly bombarded by media images.
The diathesis-stress model would say.
It might suggest that perhaps Jessica had an underlying biological or psychological vulnerability, the diathesis, maybe heightened sensitivity to mood shifts or perfectionism. Then, exposure to intense sociocultural pressure for thinness, maybe combined with specific life stressors like relationship difficulties or academic pressure, the stress, interacted with that vulnerability to trigger the onset of bulimia.
That makes a lot of sense. It weaves it all together. So what's the key takeaway here for us from this integrated model?
I think the most powerful message is that our mind and body are profoundly interconnected, and they both exist within a wider social world. Truly understanding and addressing abnormal behavior requires this comprehensive, integrated approach. You have to look at the whole person in their whole context.
Okay, that provides a really solid framework for understanding why. Now that we have these lenses, what do we actually do about abnormal behavior? Let's shift gears and talk about methods of treatment and, importantly, their effectiveness. First off, who are the helpers? It can be a bit confusing sometimes. Psychologists, psychiatrists.
It really can be. The key differences usually lie in their training and scope of practice. Clinical psychologists typically hold doctoral degrees, like a PhD or PsyD. They specialize in diagnosing psychological disorders and practicing psychotherapy or talk therapy.
Okay, PhD or CISID, focused on therapy.
And psychiatrists. Psychiatrists are medical doctors, MDs, who complete residency training in psychiatry. Because they're physicians, they specialize in diagnosis and treatment from a medical perspective. They can prescribe psychiatric medications and use other medical interventions like ECT. They may also provide therapy, but medication management is often a primary focus.
Got it. MDs can prescribe meds, and then clinical social workers.
Clinical social workers usually have a master's degree in social work, MSW, and specialized training in mental health. They often help people, particularly those with severe mental disorders, connect with community support services. They also frequently practice psychotherapy, including individual, family, or couple therapy.
It's interesting how roles can sometimes overlap but also evolve. I've always wondered, is this actually true or fiction? Some psychologists can prescribe drugs. I thought that was only psychiatrists.
That is actually true, surprisingly perhaps. In a growing number of U.S. states and in some other countries, clinical psychologists who complete specialized postdoctoral training in psychopharmacology and pass a licensing exam are authorized to prescribe psychiatric medications. It's still evolving, but it's happening.
Good to know. This does raise an important point for you, the listener. If you're seeking help, it's always a good idea to ask about a professional's specific training, credentials, and licensure. Titles like therapist or counselor aren't always regulated uniformly everywhere, so knowing their qualifications is important.
Absolutely critical.
Okay, so let's dive into the psychological methods of treatment, what most people think of as talk therapy.
Right. Psychotherapy is essentially a structured form of treatment based on psychological principles and frameworks, involving a trained therapist and a client seeking help for psychological difficulties. Let's start with psychodynamic therapy, which grew out of Freud's psychoanalysis.
Okay, what's the main goal there?
The core goal is insight, helping clients gain a better understanding of the unconscious conflicts, motives, and defense mechanisms that might be driving their current problems and relationship patterns.
And how do they get that insight? What are the techniques?
Classic techniques include free association. The client is encouraged to say whatever comes to mind without filtering or censoring thoughts, feelings, images, memories.
So this is true or fiction? In classical psychoanalysis, clients are asked to express whatever thought happens to come to mind, no matter how seemingly trivial or silly.
That's definitely true. That's the essence of free association. The idea is to bypass the ego's defenses and let unconscious material surface. Another key technique is dream analysis.
The royal road to the unconscious, Freud called it.
That's the one. Dreams have manifest content, the story you remember, and latent content, the hidden, symbolic, unconscious meaning. The therapist helps interpret the symbols. And perhaps one of the most interesting concepts here is transference.
Transference. Tell me more about that. Sounds important.
It's considered really central. Transference is when the client unconsciously responds to the therapist as if they were a significant figure from their past, usually a parent. Old feelings, attitudes, conflicts get reenacted in the therapy relationship.
So you might get angry at your therapist like you did at your dad.
Exactly. Or become overly dependent or fearful of judgment. The therapist helps the client understand these patterns as they emerge in the therapy room, providing insight into how past relationships affect the present. There's also countertransference, the therapist's unconscious reactions to the client.
Okay. Is modern psychodynamic therapy still like old school psychoanalysis, lying on a couch for years?
Not usually, no. While the core ideas about insight and unconscious processes remain, contemporary psychodynamic therapies are often much briefer, maybe face-to-face, more focused on current relationships and adaptive functioning, and how the past informs the present rather than solely dwelling on childhood.
Okay. Next up, behavior therapy. This seems much more focused on action, on changing specific behaviors.
It absolutely is. Behavior therapy applies principles of learning classical conditioning, operant conditioning, observational learning directly to change problem behaviors. It's often quite focused and relatively brief.
What are some common techniques?
Well, for fears and phobias, there's systematic desensitization. Clients learn relaxation skills and then are gradually exposed to feared stimuli, often starting in imagination while staying relaxed. Gradual exposure involves confronting feared situations in real life, step by step, at the client's pace. Very effective for anxiety disorders.
Exposure seems key.
It is. Then there's modeling, where clients learn new skills or coping strategies by observing the therapist or others. And various reinforcement techniques based on operant conditioning are used to shape desired behaviors, things like token economies in institutional settings, or using rewards for specific behavioral goals.
Okay. Then we have humanistic therapy, like Carl Rogers's person-centered therapy. Very different vibe, right?
Yeah. Totally different feel. The goal here is to help clients achieve self-acceptance, tap into their inner resources, and move towards that idea of self-actualization we talked about, becoming more authentic and fulfilled.
And the therapist's role is crucial, but in a different way.
Absolutely. Rogers emphasized the therapist's qualities as being essential for growth, providing unconditional positive regard, deep acceptance of the client as they are, empathy, striving to understand the client's world from their point of view, and genuineness or congruence, being authentic and real in the relationship.
So it's less about techniques and more about the relationship.
Largely, yes. It's considered a non-directive approach. The client leads the way, and the therapist's job is to create a safe, supportive space, often using reflection, mirroring back the client's feelings and meanings to help them clarify their own experience and trust their inner wisdom.
Okay. And cognitive therapy, back to focusing on our thoughts.
Exactly. Cognitive therapists work to help clients identify and correct distorted or maladaptive patterns of thinking that are believed to underlie their emotional problems.
Like Ellis and Beck we mentioned earlier.
Precisely. Albert Ellis's rational emotive behavior therapy, or REBT, is quite active and directive. The therapist vigorously disputes the client's irrational beliefs, those musts and shoulds, and helps them replace them with more rational, adaptive ones.
So challenging the thoughts directly.
Very directly. Aaron Beck's cognitive therapy is similar in focusing on identifying and modifying distorted thinking, like overgeneralization or absolutist thinking. A key technique is reality testing, helping clients design experiments to check out their negative assumptions. For example, if someone believes nobody likes me, they might be encouraged to actually call a few friends to test that belief against evidence.
That makes sense, testing it out. It sounds like these two approaches, behavior therapy, cognitive therapy, would blend really well together.
They absolutely do. And that blend is incredibly popular and effective. Cognitive behavioral therapy, or CBT, is arguably the most widely practiced and researched form of therapy today.
CBT, everyone's heard of CBT.
Right. It integrates both cognitive techniques, changing faulty thinking, and behavioral techniques, changing maladaptive behaviors. It's proven highly effective for a wide range of issues: depression, anxiety disorders, OCD, eating disorders like bulimia, and more. It's very practical and goal-oriented.
Okay, so those are the major individual therapies. What about therapy involving more than one person?
Good point. There's group therapy, where several clients meet together with a therapist. It has advantages like being more cost-effective, providing mutual support and shared experience, and offering a space to work on interpersonal skills and relationship patterns. Downsides can include less individual attention and some people feeling inhibited in a group.
Right.
Family therapy treats the family unit as the system. The focus is on improving communication, resolving conflicts, changing rigid interaction patterns, and understanding how family dynamics might contribute to one member's problems, avoiding scapegoating.
And couple therapy.
Focuses on the relationship between partners, aiming to improve communication, manage conflict more constructively, and increase relationship satisfaction.
Okay, a whole range of approaches. But the big question hanging over all of this is, does psychotherapy actually work? Is there solid evidence?
That's the crucial question, and the answer from decades of research is a pretty resounding yes. The evidence is quite robust.
How do we know?
A key tool is meta-analysis, where researchers statistically combine the results of many individual therapy outcome studies. These meta-analyses consistently show that the average person receiving psychotherapy is significantly better off than about 75–80% of people with similar problems who remain untreated.
75–80% better off. That's substantial.
It really is. The greatest gains often happen relatively quickly, within the first few months of treatment. Now, this raises a really interesting question.
Which is?
Is it the specific techniques of CBT or psychodynamic therapy or whatever that make the difference? Or is it something more fundamental, common across different good therapies?
The non-specific factors.
Exactly. Research increasingly highlights the importance of these non-specific treatment factors, things that aren't tied to one specific theory but are present in most effective therapies.
Like what kind of factors?
Things like the client's positive expectations or hope. The placebo effect plays a role. The therapist's qualities: warmth, empathy, support, attention. But maybe most importantly, the quality of the relationship between the client and therapist, what's called a therapeutic alliance or working alliance.
The connection matters.
It seems to matter a lot. A strong collaborative alliance built on trust and shared goals, particularly when established early on, consistently predicts better therapy outcomes, regardless of the specific techniques used.
So while specific techniques are important, and we know certain treatments called empirically supported treatments or ESTs, like CBT for panic disorder or exposure therapy for specific phobias, have strong evidence for particular problems.
Right.
These common factors, especially the therapeutic relationship, seem to be powerful healing ingredients in themselves.
That seems to be the case. And remember that mind-body connection. There's even intriguing recent neuroimaging research showing that psychotherapy, specifically CBT in SNEAM studies, can lead to actual structural and functional changes in brain regions involved in emotion regulation and self-control.
So talk therapy can literally change your brain.
It suggests it can, yes. Underscoring again that deep link between psychological experience and brain function.
Okay, beyond the techniques and the alliance, it seems absolutely vital today to consider multicultural issues in psychotherapy. Why is cultural competence so critical for therapists?
It's essential because we live in incredibly diverse societies. Normal behavior, abnormal behavior, how stress is expressed, attitudes towards seeking help, all these things are shaped by culture. Therapists need to be culturally competent, meaning they need to understand and respect cultural differences, possess knowledge about the cultural backgrounds of their clients, and be able to apply that knowledge effectively and sensitively in therapy. It's more than just good intentions. It requires specific awareness and skills to avoid misunderstandings or even harm, like ethnic stereotyping.
Can you give us some specific examples? How might culture influence the therapy process for different groups?
Sure. For example, with some African American clients, therapists should be aware of the historical context of racism and discrimination, which might lead to understandable caution or mistrust of institutions. Recognizing the importance of kinship networks, spirituality, and being mindful of negative cultural stereotypes is crucial.
Okay. What about other groups?
For many Asian Americans, cultural values might emphasize emotional restraint, so directly expressing intense feelings might be uncomfortable. Distress might also be expressed physically somaticized, as headaches or fatigue, rather than talked about emotionally. Also, the strong emphasis on individualism in much Western therapy can clash with more collectivistic Asian values where family and community harmony are paramount.
That makes sense. And for Hispanic Americans or Native Americans?
For many Hispanic Americans, the concept of familismo, the importance of the extended family, is central. There's also the value of respeto, respect in relationships. Therapists need to understand potential cultural conflicts like between traditional interdependency and mainstream emphasis on independence, and be aware of unique culture-bound syndromes like ataque de nervios, which are intense anxiety reactions understood within that cultural context. For Native Americans, again, the history of marginalization is crucial. Many may prefer traditional healers or find a cultural gap with mainstream mental health services. Effective approaches often need to incorporate tribal culture, values, and perhaps traditional ceremonies, respecting indigenous ways of healing.
These cultural factors clearly highlight some significant barriers to receiving care for people from ethnic minority backgrounds, don't they?
They really do. Despite often having, as we said, lower rates of current disorders, ethnic minorities in the U.S. consistently underutilize mental health services compared to white Americans. And when they do access care, it's sometimes of lower quality.
Why is that? What are the main barriers?
There are several key ones. Cultural mistrust, stemming from historical and ongoing experiences of racism and oppression. Lack of mental health literacy or information about services. Institutional barriers, like services being inaccessible, bureaucratic, or not culturally sensitive. Cultural stigma associated with mental illness within some communities. Language barriers, obviously, and practical issues like cost and lack of insurance or transportation.
So addressing these barriers is critical for making mental health care truly equitable and effective for everyone in our diverse society.
Absolutely essential.
Okay, finally, let's turn to the biomedical therapies. This is often the medical toolkit, medications, ECT.
Right. There's definitely been a growing emphasis on using psychotropic or psychiatric drugs in recent decades. I think the statistic is something like 1 in 5 American adults takes at least one psychiatric drug.
1 in 5, wow.
Yeah. These drugs, typically prescribed by medical doctors, aim to control troubling symptoms of psychological disorders. But it's really important to stress they are generally not considered a cure for the underlying conditions. They help manage symptoms.
Okay, symptom control, not cure. What are the major categories of these drugs and how do they work, generally?
Okay, first you have anti-anxiety drugs, also called anxiolytics or minor tranquilizers. Common examples are Valium, Xanax, Ativan, the benzodiazepines. They work quickly to reduce anxiety and tension by calming the central nervous system, basically enhancing the effects of the inhibitory neurotransmitter GABA.
Sounds helpful, but are there downsides?
Definitely. They are effective for short-term relief, but they carry significant risks of psychological and physical dependence, drowsiness, impaired coordination, and potentially dangerous interactions with alcohol. Plus, stopping them abruptly can cause rebound anxiety, sometimes worse than the original symptoms. So generally, short-term, carefully monitored use is recommended.
Okay. What about drugs for more severe conditions, like psychosis and schizophrenia?
Those are the antipsychotic drugs, sometimes called neuroleptics. The first generation, like Thorazine and Haldol, emerged in the 1950s and were truly revolutionary. They significantly reduced the most dramatic symptoms of schizophrenia, hallucinations, delusions, disordered thinking, largely by blocking dopamine receptors in the brain.
They allowed many people to leave hospitals.
Right. Huge impact on deinstitutionalization, yes. But these older drugs often have severe side effects, including muscle rigidity, tremors, and most concerningly, tardive dyskinesia, or TD. It's a potentially irreversible neurological disorder involving involuntary repetitive movements, often of the face, mouth, and limbs. Newer atypical antipsychotics like Clozaril, Risperdal, Zyprexa generally have a lower risk of TD, though they carry other risks like weight gain and metabolic problems.
Okay. Now, antidepressants. We hear a lot about these. It's a common assumption they're only for depression. True or fiction? Antidepressants are used only to treat depression.
That is definitely false. While they are, of course, widely used to treat depression, typically by increasing the availability of neurotransmitters like serotonin and norepinephrine in the brain.
Like the SSRIs, Prozac, Zoloft.
Exactly. Selective serotonin reuptake inhibitors, SSRIs, are very common. There are also SNRIs like Effexor and older classes like tricyclics and MAOIs. But yes, the statement is false because these drugs are also very effective and commonly prescribed for a surprisingly wide range of other disorders. Things like panic disorder, obsessive-compulsive disorder, OCD, social anxiety, PTSD, and even eating disorders like bulimia nervosa.
Interesting. So they have broader effects than the name suggests. What about for bipolar disorder with those extreme mood swings?
The primary mood stabilizer for bipolar disorder has long been lithium carbonate. It can be very effective in reducing mood swings, both mania and depression, but it requires careful blood monitoring due to potential toxicity. Other drugs, particularly certain anticonvulsant medications originally developed for epilepsy, like Depakote or Lamictal, are also frequently used as mood stabilizers, sometimes when lithium isn't effective or tolerated well.
Okay, shifting gears from pills to more direct brain interventions. Electroconvulsive therapy, ECT. This sounds pretty intense, maybe even scary to some people.
It does sound intense, and it remains controversial. ECT involves passing a controlled electric current through the brain, intentionally inducing a brief seizure.
Why would you do that?
It's used primarily for severe depression, particularly when it hasn't responded to medication or psychotherapy, or when there's a high risk of suicide and rapid improvement is needed. So, true or fiction? Sending jolts of electricity into a person's brain can often help relieve severe depression.
Given it's still used, I'm guessing true.
It is true. For some people with severe treatment-resistant depression, ECT can produce dramatic and rapid relief when nothing else has worked. However, it does have significant limitations.
Such as?
The main side effect is memory loss, particularly for events around the time of treatment, though sometimes it can be more extensive or persistent. Also, relapse rates after ECT are quite high unless follow-up treatment like medication or therapy is continued, so it's generally considered a treatment of last resort for specific situations.
Okay. And what about psychosurgery? I mainly associate that with historical procedures like lobotomies, which sound pretty horrifying.
Yeah, psychosurgery is even more controversial and extremely rare today. The infamous prefrontal lobotomy, which involves surgically severing nerve pathways in the frontal lobes, was widely used in the mid-20th century, but largely abandoned due to its severe and often devastating side effects on personality and intellect.
So it's not really done anymore.
Not in that crude form, no. However, there are modern, highly targeted neurosurgical techniques being explored for very severe, intractable cases of disorders like OCD or depression that haven't responded to any other treatment. Things like deep brain stimulation, DBS, where electrodes are precisely implanted in specific brain areas, are still largely experimental but represent a much more refined approach than the old lobotomies. Still very much a last resort, though.
Okay, so wrapping up these biomedical treatments, what's the big picture message for us?
I think the key message is that biomedical treatments, especially medications, have undeniably helped millions of people manage debilitating symptoms and live more functional lives. They are a vital part of the toolkit. But it's crucial to remember they aren't usually cures, they target symptoms, and they almost always come with potential side effects and risks that need careful consideration.
And they aren't the only option.
Absolutely not. Psychotherapy can be just as effective, sometimes more effective in the long run for certain problems, and often works best when thoughtfully combined with medication. It's really a caution against seeking a quick pill for every problem without also exploring psychological and social factors and potentially engaging in therapy to address the underlying issues and build coping skills. A balanced perspective is key.
Wow. We have covered a lot of ground today. We've journeyed through this really complex landscape, unpacking contemporary perspectives on abnormal behavior, understanding the methods of treatment. We've seen how behavior is viewed through its biological roots, the intricate layers of the mind, the powerful influence of society, all culminating in that really helpful integrated biopsychosocial view. And then we explored the different types of helpers and the huge range of treatments, from talk therapies to medications and beyond.
It's clear, isn't it? The human experience, especially when distress is involved, is just incredibly multifaceted. Each perspective we discussed offers a valuable window, a different angle for understanding, and each treatment approach provides unique tools. There's rarely one single right answer.
So considering all these different perspectives we've talked about, what really stands out to you, the listener, about this profound interconnectedness, mind, body, social world, in shaping our mental health? And maybe think about this. How might our evolving understanding, like epigenetics or the effectiveness of therapy on brain function, challenge some traditional ideas about responsibility or illness? What new questions does that raise for the future of how we understand and treat these conditions?
Yeah, lots to think about. This deep dive is really just a starting point. The complexities of human behavior, well-being, and distress are vast. We really encourage you to keep exploring, keep learning,